Good morning. Today I will present this talk for sixth-year medical students to give them useful tips for history examination and evaluation and diagnostic approach to a child with anemia. As you know, it's not possible for a good number of students to attend the hospital and have a clinical session in the hospital because of corona virus pandemic. So I will try in this presentation to mention important tips from clinical points of view, and I hope it is useful for you all. So the objectives of this presentation, we will review issues related to history and physical examination, initial laboratory workup, method for classifying anemia, and finally, I will send you algorithm designed to help guide the diagnosis. How we define anemia? Anemia may be defined as a reduction in red blood cell mass or hemoglobin concentration. The hematocrit or RBC mass is the fractional volume of whole blood sample occupied by RBC expressed as a percentage. If you have a test tube contain blood and put it in centrifuge, then the lower part is the packed cell volume or the hematocrit, which is different according to different age group and also by gender. Hemoglobin is the measure of concentration of RBC pigment, hemoglobin in whole blood. It is expressed as a gram per 100 ml of whole blood. Normal ranges for both hematocrit and hemoglobin varies with age, race, and gender. The threshold for defining anemia is when hematocrit or hemoglobin at or below 2.5th percentile for age, race, and sex. We will start with patient characteristics according to age. From birth to 3 months, the most common cause of anemia in a young infant is physiologic anemia, which occur between 6 to 9 weeks of age. As you know, erythropoiesis decreases dramatically after birth due to increased tissue oxygenation and decreased production of erythropoietin. In utero, the oxygen tension is low, about 65%. That's why the fetus has high level of hemoglobin to deliver more oxygen to the tissue, but after birth, with expansion of the lung and rise in oxygen saturation to 100%, this will lead to decrease in erythropoiesis and a subsequent drop in hemoglobin and decrease the production of erythropoietin. In healthy term infant, the hemoglobin level, as I said, is high, more than 14 gram. It's around 20 gram per DL. They rapidly decline, reaching a nadir of approximately 11 gram per DL at 6 to 9 weeks of age. This is called physiologic anemia of infancy. We have other causes of pathologic anemia in a newborn, which is different from physiologic anemia, and this include blood loss, immune hemolytic disease like RH or ABO incompatibility, congenital infection, twin-to-twin transfusion, and congenital hemolytic anemia like hereditary spherocytosis and G6PD. The preterm infant who born with lower hematocrit and hemoglobin, they will have shorter RBC lifespan and impaired erythropoiesis production due to immature liver function. So the decline in RBC production occurs earlier after birth and more severe than anemia seen in term infant. This is called anemia of prematurity. In infant 3 to 6 months, here anemia detected is due to hemoglobinopathies like thalassemia and sickle cell anemia. Nutritional iron deficiency is an unlikely cause of anemia before age of 6 months in term infant. However, iron deficiency anemia can present before 6 months in children who are delivered preterm. As you know, the transfer of iron from the mother to the fetus occurs mainly in the third trimester, and those who deliver the preterm, they have low reserve of iron from their mother and are more liable to develop iron deficiency anemia at earlier ages. Toddler children and adolescent acquired causes of anemia are more likely, especially iron deficiency anemia, because it is a period of rapid growth. Screening for iron deficiency is recommended in all children at age of 9 to 12 months of age. It is the most common type of anemia globally and responsible for 30% of causes of anemia worldwide. What are the patient characteristics? Gender is very important, and some inherited causes of anemia are extinct, like G6PD and other types of congenital anemia occur most commonly in males, while in postmenarchal girls, excessive menstrual bleeding is an important cause anemia like von Willebrand disease. Now, what about race and ethnicity? They are helpful in guiding the workup, for example, in hemoglobinopathy and enzymopathy, like hemoglobin S and C are most commonly seen in a Black and Hispanic population. Also, enzymopathy, we have a type present in Mediterranean region, another type present in Black people, another type is present in Asian people, what it's called the Canton type of G6PD, while the Mediterranean type is the B type and the Black people have A type. Thalassemia syndromes are more common in individuals of Mediterranean and South Asian descent. Alpha thalassemia is more common in South Asian descent, while beta thalassemia in Mediterranean region. As I mentioned, G6PD is more common among Sephardic Jewish, who are Mediterranean people, Filipinos, Greeks, Sardinian, Kurds, and a Black population who have different type of G6PD deficiency. Now we concentrate on points related to the history. The evaluation of a child with anemia should begin with thorough history, which the degree of symptoms, past medical history, family history, dietary history, and developmental history. All these provide important clues to the cause of anemia. First, we start with the symptoms, which help elucidating severity and the chronicity of anemia and identify patient with a blood loss or hemolytic etiology. So the symptoms of anemia depend on the rapidity of the onset. The more acute the onset, the more likely to have severe symptoms. The common symptoms of anemia include lethargy, tachycardia, pallor, and infant may present with irritability and poor oral intake. However, the body has compensatory mechanism in patients who have long-standing anemia, and all these mechanisms are mentioned in your fifth-year lectures. And with this compensatory mechanism, I will mention it, an increase in T3 diphosphoglycerate, which affect the affinity between hemoglobin and oxygen to make oxygen more readily delivered to the tissue, an increase in erythropoietin production by the kidney, redistribution of blood flow to more vital organs like heart, CNS, and muscle, and finally an increase in cardiac output to compensate for this decrease in hemoglobin, especially when hemoglobin decreases below 7 grams per DL. That's why chronic anemia may have a few or no symptoms compared to those with acute anemia at comparable hemoglobin levels. The symptoms of hemolysis, like changes in urine color, jaundice, may indicate the presence of hemolytic disorder, and hemolytic episode may only occur in male family member, indicate the presence of G6PD, a sex-linked recessive disorder. Presence of bleeding symptoms also important, like GIT, bleeding, epistaxis, bleeding per rectum, other occult bleeding from GIT. Severe or chronic epistaxis may also result in anemia and iron deficiency. An adolescent girl menstrual history should be obtained. So it's very important to determine whether there is a family history of inflammatory bowel disease, intestinal polyps, other bleeding disorders like von Willebrand disease, platelet disorder, or coagulation defects like hemophilia. Past medical history is important and we should focus on episode of anemia and underlying medical condition. So we start from birth history, which it should include gestational age, as we mentioned, important to be assessed, the duration of birth. Sometimes the prolongation of birth might lead to more loss of blood from the baby or during birth process, hospitalization, and aspiration of a frequent sample for investigation and due to any cause of admission, history of jaundice and or anemia in neonatal period. Also result of a newborn screening, which includes screening for sickle cell disease. Should all these should be reviewed. Also, history of anemia, we should assess a previous complete blood count. Prior episode of anemia may be suggestive of inherited disorders, whereas anemia in a patient who is previously documented to have normal complete blood count suggests an acquired etiology. Also, patients with certain hemoglobinopathies may vary with history of a treatment on multiple occasions, especially children with beta thalassemia trait may have erroneous diagnosis of iron deficiency anemia and given iron treatment, while they are not iron deficiency anemia, but beta thalassemia minor. Also, underlying medical condition to elucidate these chronic condition like a chronic liver disease and chronic renal disease, which are or any other chronic disease which might lead to anemia. Travel to or and from area of endemic infections like malaria, hepatitis, tuberculosis. Recent illnesses should be reviewed to investigate for possible infectious etiology of anemia. Drug and toxin exposure is very important. Current and past medication like herbal supplement should be reviewed with the particular attention to oxidant drug that can cause hemolysis in patients with G6PD deficiency. Possible environmental toxin exposure should be explored, especially lead poisoning and nitrate in people drinking well water. Dietary history is focused on assessing iron intake and to lesser extent folate and B12 content, the type of diet, type of formula, whether iron fortified or not, age of infant at time of discontinuation of formula, and the breast milk should be documented. In addition, the amount and type of milk the patient is drinking should be determined. For example, cow milk shouldn't be given under the first year of life because it might cause iron deficiency anemia. Infant and children who are exclusively fed goat's milk can develop anemia because goat milk is deficient in folate. Pica, especially pagophagia, eating of ice may suggest lead poisoning and or iron deficiency anemia. Another points in the history is family history by asking about history of jaundice, gallstones, or splenomegaly should be identified. Ask if family member have undergone cholecystectomy or splenectomy. It may aid in identification of individuals with inherited hemolytic anemia. Developmental history, we should ask the parent to determine if the child has reached age-appropriate developmental milestone, and this is especially associated with iron deficiency and to lesser extent vitamin B12 and folic acid deficiency. Why? Because as you know, iron is an important coenzyme for cytochrome, which as a neurotransmitter is essential for the neurodevelopmental function of the brain. So children with iron deficiency anemia, they may have behavior disturbance at school, they have short attention span, lack of concentration due to deficiency in cytochrome enzyme. Also, patients with Fanconi anemia, 10% of them, they are liable to have mental retardation. On physical examination, we should focus on examination of the skin for pallor, jaundice, other causes like bleeding tendency, cafe au lait spots, palmar erythema, spider nevi, capillary hemangioma, earthy color in uremia. Also assess the eyes, the mouth, facies, chest, hand, and abdomen for organomegaly or signs of portal hypertension like ascites and splenomegaly. Pallor is assessed by examining the site where capillary beds are visible, like conjunctiva, palm, and nail beds. Patients with hemolytic process resulting in anemia, as we mentioned, may present with signs of jaundice, hepatosplenomegaly, resulting from increased red cell destruction and extramedullary hemopoiesis, like in thalassemia. So now we start with laboratory evaluation. It should include initially completed blood count with RBC indices and review of peripheral blood smear. Also, reticulocyte should be obtained, although it is not necessary for diagnosis of iron deficiency anemia in children less than 2 years old who present with mild microcytic anemia and suggestive dietary history. Complete blood count to provide information about RBC and other cell lines like white BC and the platelets, hemoglobin and hematocrit. We should assess the normal ranges, which vary substantially with age, and it is important to have adjusted norms for age and sex. RBC indices are integral part of evaluation of anemic child, like mean cell volume, mean cell hemoglobin, and mean cell hemoglobin concentration. The mean cell volume is measured directly by automated blood cell counters, and it is a normal values for it varies upon age. Usually infants have increased MCV compared with older children. Also in a preterm infant, the MCV values increase with decreasing gestational age. MCV is the most useful RBC parameter in evaluation of a patient with anemia and used to classify anemia as follows. The microcytic anemia defined as anemia with low MCV value, that's to say equal or less than 2.5 percentile for age, race, and gender. Normocytic anemia, normal MC value, that's to say between 2.5 and 97.5 percentile for age, race, and sex. Macrocytic anemia defined with a high MCV value, that's to say equal or more than 97.5 percentile for age, race, and sex. Because retics have a greater mean cell value than do mature cells. As you know, retics are young RBC released from circulation to compensate for loss in RBC due to any cause. They are big in size and contain nucleus due to residual RNA present in them. Patients with significant degree of reticulocytosis, as I mentioned, they will have elevated MC values in face of otherwise normocytic RBCs. How do we assess white blood count and the platelet count? It may provide a clue to underlying cause of anemia. For example, leukocytosis suggests infectious etiology or an acute leukemia. Thrombocytosis is a common finding in iron deficiency anemia and as a part of acute phase reaction in response to infection and other inflammatory conditions, especially Kawasaki disease. Leukopenia, neutropenia, and thrombocytopenia, as you know, signify abnormal bone marrow function or increased peripheral destruction of blood cells. Causes of bone marrow suppression or failure include drugs or toxins like chloramphenicol or benzene, nutritional deficiency like folic acid and vitamin B12, rarely iron deficiency because folic acid and B12 are essential for nucleic acid synthesis in the bone marrow and formation of a blood element, acute leukemia or aplastic anemia. An increased peripheral destruction of a blood cell may be due to splenic hyperfunction and hypersplenism due to any cause, microangiopathic anemia like hemolytic uremic syndrome or Evans syndrome, which is a variant of autoimmune hemolytic anemia and autoimmune thrombocytopenia. The blood smear is an essential part of any anemia evaluation. Even if RBC indices are normal, we should review blood smear, which might reveal abnormal cell that help identifying the cause of anemia, like the following: fragmented RBC and microangiopathic anemia, sickle cell and sickle cell disease target cell seen in various hemoglobinopathies like thalassemia, sickle cell, liver disease, and post-splenectomy. Also, bite cells and Hyan's body seen in hemolytic anemia due to oxidant sensitivity as G6PD deficiency, and Hyan's body composed of stromal protein with denatured hemoglobin seen in the first few days after hemolysis. Then it disappeared rapidly from circulation because they are removed by the spleen. Presence of nucleated RBC indicate rapid bone marrow turnover as seen in hemolytic anemia, red blood cell agglutination in autoimmune hemolytic anemia, and Howell-Jolly body associated with absence of hypofunction of the spleen. Also, the presence of patients' leukocytes should also be noted, for example, an increasing and circulating neutrophil like band form or toxic granulation, or the presence of atypical lymphocytes suggests possibility of bacterial infection, and with the presence of band form and toxic granulation, or viral infection with atypical lymphocyte like EB virus or other inflammatory conditions. Hypersegmented neutrophil suggestive of vitamin B12 or folate deficiency in megaloblastic anemia. Presence of early white blood cell form, for example, a blast, along with anemia should raise suspicion of leukemia or lymphoma, which is very rare to have. Leukemia and lymphoma. Lymphoma, we can have anemia, but unusual to have bleeding. Reticulocytosis, the retic are the youngest RBC, as I mentioned, and identified by residual RNA or nucleus. They are reported as percentage of RBC population. And after the first few months of life, the normal retic percentage is the same as that for adult, approximately 1.5%. An absolute reticulocyte count expected to increase in the presence of anemia, although laboratory do not provide normal range, which is adjusted to the level of anemia. So anemia with high absolute retic count reflect an increased erythropoietic response to hemolysis or blood loss, while anemia with low or normal absolute retic count reflect deficient production of RBC, thus to say reduced marrow response to anemia, for example, in a pure red cell aplasia and aplastic anemia. How we approach that, what is the diagnostic approach for a child presented with anemia, depend on history, examination, and laboratory test. It will narrow the diagnostic possibility and guide us for further testing. First, abnormality in other cell lines. If there is anemia with abnormality in other cell lines, the first step in narrowing the diagnosis is determining whether the patient has isolated anemia or other cell lines affected like white BC and the platelet. Also, when there is pancytopenia, it includes leukemia, infection, myelosuppressive medication, chemotherapy, aplastic anemia, and hypersplenism. Anemia with a thrombocytopenia like hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and Evans syndrome just mentioned. Anemia with a thrombocytosis and iron deficiency anemia. Other causes are post-splenectomy anemia and infection or inflammation, as we said, thrombocytosis and acute phase reaction, while anemia with leukocytosis is associated with infection and leukemia. How we classify anemia, as we mentioned already, we depend on RBC size and physiological response of the bone marrow, that's to say the retics response. The microcytic anemia is defined again with low mean corpuscular volume less than 2.5 percentile for age, race, and sex, and the most common cause is iron deficiency anemia and beta thalassemia. The normocytic anemia, as it is defined already, and common causes include hemolytic anemia, blood loss, infection, medication, and anemia of a chronic disease. While microcytic anemia is caused by medication like anticonvulsant, phenytoin. Most of these anticonvulsant can cause megaloblastic anemia, immune suppressive agent, or chemotherapy. Other causes B12 and folate deficiency, liver disease, and aplastic anemia. Retic count is helpful in evaluation of children with normocytic anemia. As we mentioned also, a high retic count, more than 3%, reflect increased erythropoietic response to blood loss or hemolysis like hemorrhage, autoimmune hemolytic anemia, hereditary spherocytosis, G6PD, sickle cell anemia, and hemolytic uremic syndrome. While low or normal reticulocyte count, it indicates reduced marrow response to anemia. It includes infection, lead poisoning, hypoplastic anemia, drugs, and kidney disease. In addition, anemia due to acute blood loss may be associated with low absolute reticular count because there is not enough time for the bone marrow to increase appropriate reticulocyte response, which typically takes place after 1 week. Other confirmatory tests if hemolytic anemia is suspected, so testing should include serum indirect bilirubin and lactic dehydrogenase, which increase in hemolysis, while we have decrease in haptoglobin level due to saturation by destroyed hemoglobin. Testing for a specific etiology may include antiglobulin or Coombs test, G6PD deficiency screening test, osmotic fragility in hereditary spherocytosis, and or hemoglobin electrophoresis for beta thalassemia and sickle cell disease. Bone marrow aspirate and or biopsy may be necessary for evaluation of leukemia and other bone marrow disease, for example, aplastic anemia. If iron deficiency anemia is suspected, then additional studies include serum ferritin, iron, and total iron binding capacity should be done. Iron studies are not necessary. Again, it was mentioned already, in less than 2 years of age, because those present with mild microcytic anemia, suggestive dietary history. And in these cases, a therapeutic trial of iron may be used to confirm the diagnosis in these children. Testing for other deficiencies and or lead poisoning may include serum folate, B12, and lead levels, especially in areas where there is heavy exposure to lead levels in lead factories. In summary, the threshold for defining anemia is hemoglobin or hematocrit less than 2.5 percentile for age, race, and sex. Hemoglobin level are high at birth, they rapidly decline, reaching nadir of approximately 11 gram per DL at 6 to 9 weeks of age, which is called physiologic anemia of infancy. The causes of anemia vary based upon age at presentation. In neonate and young infant, immune hemolytic disease, infection, hereditary disorders are most common, while in older children, acquired causes of anemia are more likely, especially iron deficiency anemia or blood loss. The key historical factor in assessment of a child with anemia includes severity and onset of anemia, evidence of jaundice or blood loss, GIT symptoms and menstrual history, drug and toxin exposure, chronic diseases, family history of anemia or hemoglobinopathy. The physical examination should include assessment for pallor, scleral icterus, jaundice, hepatomegaly, and splenomegaly, while lab examination should begin with complete blood count, including RBC indices, reticulocyte count, and review of peripheral blood smear. Examination of a blood smear may reveal features suggestive of the cause of anemia and help to evaluate possibility of hematologic malignancy. The MCV provide a preliminary categorization of anemia, which guides additional testing. Common causes of microcytic anemia is iron deficiency and thalassemia, while common causes of normocytic anemia include hemolysis, blood loss, infection, medication, and anemia of a chronic disease. Common causes of macrocytic anemia include medication, anticonvulsant drugs, and B12 folate deficiency. The reticulocyte count distinguished disorder resulting from rapid destruction or loss of RBC from disorders result in an inability to adequately produce RBC. Hemolysis and bleeding usually associated with high retic count more than 3%, whereas bone marrow depression is associated with low reticulocyte count. Once the diagnostic possibilities have been narrowed based upon RBC indices and reticulocyte response, then further confirmatory testing is performed. Thank you. I will stop here, and I hope this presentation is useful for you and give you important clues for history examination, lab evaluation, and diagnostic approach for a child presented with anemia. Again, I wish you success in your final exam, and we hope that this pandemic will end soon and we return to our normal life and see you again in our hospital with the patient, studying all together the medicine and learn from the patient. Thanks so much.